start.
Yeah. Guys, a warm good afternoon and a good evening to all of you. And today we are going to start with a very basic topic. And this topic is perhaps one of the most important topic, because whatever you get, whether it's a long case or a short case or whatever it is, an examination of a swelling or a lump forms the basis of what is a surgical exam. And therefore, what I intend to do today is tell you about the basic approach, the clinical methods, and then a sort of differential diagnosis algorithm so that you can approach to any problem while you are facing a case during the exam. To begin with, I would start by giving you a sort of algorithm or a sort of mnemonic which you need to remember. And it starts with a 4S. And this S begins with a site. Then it goes through the size. Then it goes through the shape. Then it goes to the surface. After that, you have C, which comprises of the consistency of a swelling. Then you have M, that comprises of the margin. Then you have R, which comprises of the reducibility of a swelling. Then you have C, that comprises of the compressibility of a swelling. Then you have P, which comprises of a pulsatility of a swelling. Then you have R, which with the surrounding structures. Then you have D, which means a distal limb or the distal structures. And finally L, which comprises of the lymph nodes. So basically it comprises of 4SC, MRCP, and RDL. So if you keep this in mind, you know what are the basic things you are supposed to look at while you are doing an examination of a lump or a swelling. Now, to begin with, of course, this is usually a short case or a part of a long case when you are asked to examine a patient and describe a swelling. And so the history in gist would just begin with how it started and how fast it's progressed, whether it's an acute onset or it's a slow, insidious onset, a rapid progression or not. And then you go into the inspection. And as you go into the inspection, as you see, the first point is the whole thing is the site. Now, if I can have somebody who is going to exactly tell me where this swelling is located. Can I have a volunteer, please? Now, suppose this is the Adam's apple, and this is the suprasternal notch, and then you have a swelling which is situated here, and this is the sternocleidomastoid muscle, suppose. And can anybody describe this swelling, where it is exactly located? Can I have a volunteer, please?
Sir, just medial to the sternocleidomastoid and to the right side of the thyroid cartilage.
Thyroid cartilage, that's fine. And anybody else who would like to add something to that? Okay. Now, let me give you an analogy to begin with how you exactly anatomically define the location of a swelling. It is like Sanjay trying to describe to Dhritarashtra the war that is happening, the war which is known as the Kurukshetra. So if a blind person is looking at your description, should be able to tell exactly or navigate exactly where it is situated. Now, doesn't it seem a better description if I tell I can see a swelling in front of the neck, which is say approximately a centimeter from the midline. It is on the lateral aspect. It is abutting on the anterior border of the sternocleidomastoid muscle. The upper edge of the swelling is at par of the Adams level, and the lower edge of the swelling is approximately 2 centimeter from the medial edge of the clavicle. Do I make a point? So that is an exact anatomical location of a swelling. Clear? Now, in places where you have a defined quadrant, like you are dealing with a swelling in the breast, then the matter becomes easy. I mean, you have a definition. If you tell somebody, sir, I can see a swelling which is situated in the upper outer quadrant, the medial edge of the swelling is approximately a centimeter from the lateral edge of the nucleareolar complex and extends towards the axillary extension of the breast. The upper extent of the swelling is approximately 3 centimeter from the mid-clavicular point, and the lower edge of the swelling is approximately 2 centimeter from an imaginary line passing through the nucleareolar complex. That makes sense. You have exactly defined where the swelling is. Now, coming to the abdomen. Yeah, I hope if you could stop your background description or mute yourself so it becomes easier. Now look at the abdomen. In abdomen, things become far more easier because if you have a defined abdominal quadrants, and you can always tell that I can see a swelling which is situated, say, partly in the epigastrium, the right hypochondrium, the right lumbar, the epigastric region, and the umbilical region. So that makes sense. You are able to describe it exactly. But it becomes easier if you tell that the lower edge of the swelling is situated just a centimeter above a transverse line passing through the umbilicus. So that makes it more defined. So try to describe a swelling's site or anatomical site precisely in relation to a fixed anatomical structure so that somebody can form an idea where exactly a swelling is situated. Does it make sense? Anybody who has got a query on this? Okay. So this is on inspection, and then you are going to say roughly the swelling is, suppose if we discuss this swelling, we can always say roughly a swelling which is situated in the neck and blah, 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 blah space. The size of the swelling approximately is 3 centimeter by 3 centimeter. It appears to be ovoid in shape. The surface appears to be smooth. And this is what you can exactly tell. Now look at C, you cannot describe consistency, but you can describe the swelling's margin. Now try to understand how exactly you are going to describe a margin. Now I give an example. Now always when you are looking at a margin which is placed like this, quite often you do not get all the margins very well defined. So you are going to tell superior, inferior, this is the medial and the lateral edge or the margin of the swelling. You are going to tell, sir, I can see a swelling. The superior margin of it is well defined. The inferior margin of the swelling is well defined. The medial margin of the swelling is well defined, whereas the lateral extent of the swelling is ill-defined and it merges with the anterior edge of the sternocleidomastoid muscle. So basically, when we are describing a margin, we should not be generic. We should be stating in terms of medial, lateral, superior, inferior. And therefore, some of the margins may be ill-defined, whereas some of the margins may be well-defined. Clear? Now comes the question of reducibility. Now on inspection, when you are looking at a reducible swelling, like for example, when it is situated in the groin, when it is situated in the groin, now this is a swelling which an individual tells that he can feel somewhere in the groin. Now, if you are looking at a swelling which is situated in this region and you think it could be a hernia, so you are going to tell without touching, sir, can you just lie down and make it reducible, or can you, with the use of your fingers, reduce the swelling inside? So if the patient tells, yes, sir, I can do that, he lies down and it disappears, then you are going to tell, sir, the swelling disappears on lying down, or the patient maneuvers it to put it inside. So the swelling on inspection appears to be a reducible one. The next, in case of hernia, something important that comes up with reducibility is expansile impulsion cuffing. You can ask the patient to cuff, and if the swelling suddenly increases in size, you know it's a hernia or something which is inside a body, a coelomic cavity is coming out. Compressibility would be able to examine on inspection. Pulsatility you can. Now, if you are asked to suppose a look at an abdominal swelling, now look here, we are looking at an abdomen of a person. A patient is lying down like this. Okay, and this is the abdomen of a person, and you find the swelling situated here, and which is most probably arising from the aorta, or it is connected with the aorta, and the swelling is pulsatile like this on both axes. So the way you are going to look at it is, if this is the bed and this is the patient lying down, you are supposed to sit on a chair like this and put your eyes at tangentially with the abdomen. That means tangentially you are looking at here. You are sitting by the side of the patient, putting your eyes tangentially at the level of the abdomen to see whether things are pulsating or not. So if you find that it is a pulsatile swelling, you find the expansion on visible on your inspection, you are going to comment, sir, I can see a swelling within the abdomen, which is situated in the epigastrium, partly into the umbilical region, extending into the right hypochondrium. And when I sat by the side of the patient and placed my fingers at tangentially to the level of the abdomen, I could find the swelling to be a pulsatile one. On inspection, I won't be able to comment whether it's a transmitted or it is an expansile pulsation, which we will demonstrate while you go for the palpational technique. Clear? Now coming to the relationship of the swelling. Now look carefully, what do I mean by the relationship of a swelling? Now suppose I am looking at an individual who is having a swelling in the lower extremities. For the sake of hypothesis, let us see, this is a gentleman's thigh, and this is the knee joint, and there is a swelling somewhere here, bulging like this, with the skin being going up because of the increasing size of the swelling. So when you are looking at the swelling on inspection, at best, you can tell the relationship of the swelling with the overlying skin. You can tell whether it has involved the skin or not, whether it has formed an ulceration of the skin or not, whether there are satellite nodules in the skin or not, and nothing more than that. So apart from this, on inspection, you won't be able to comment what exactly is the relationship of the swelling with the underlying muscles or to the surrounding fat. So that you won't be able to comment, or for that matter, the bone inside. So you won't be able to comment about that, but you can only comment about the relationship of the swelling with the overlying skin. And that is what you are going to comment. Now, when I talk about D or the distal limb being examined, always remember that not quite infrequently, and I can tell you a story of one of my candidates who was appearing for the exam. Now, this is quite an interesting swelling. He got a patient who had a swelling which was situated in this is the femoral triangle, suppose, on the right side, and the swelling was situated somewhere here. Now, if I think this is the groin and the swelling was situated here. So he was asked, now look at this swelling. This guy was very confident and a very good student, and he could comment, sir, this is a swelling which is situated below the inguinal ligament. It is situated in the region of the femoral region, and I think it's a clear-cut case of a femoral hernia. And he would ask the patient, can you cough? The patient couldn't, and the examiner asked, so it didn't have a cough impulse. So he told, but sir, quite often a femoral hernia, if it is irreducible, may not have what we call an expansile impulse and coughing. Now this candidate failed. The reason being, when the examiner came and asked the patient's lower the cover to be removed, they could find that the limb was edematous. That was because this was a large fixed lymph node and it was compressing on the vein and it was compressing on the artery, and therefore the tip has become gangrenous and the limb has become swollen because of the compression of the vein. So do not, for God's sake, forget to examine the limb distal too, where the swelling is situated, and therefore the D part becomes very important. Finally, the L part, again that is important. Now I tell you why. Now suppose you get a patient who has got a swelling, say a big one here, and you could, the gentleman told him that there was a swelling in the lower limb, it has been growing in size. You told all the above, the S, C, M, R, C, P, R, D. You have forgotten to examine the lymph node, and now the examiner comes, opens the private parts and find there are certain lymph nodes which are situated in the inguinal region. That means this is a metastatic node from here, and if you have not examined the local part or inspected the local part, you won't be able to make a comment whether this gentleman has got a proximal nodal metastasis. So that I would state are the pillars of examining on inspection of a swelling. Is there any question from anybody's side on inspection? Then I will move to the palpation. Any questions? Okay. So,
sir, could you please explain the lymph node metastasis part once again?
Okay. Now this is on, we are still on inspection. We have not moved on to the palpation. Now this is a big swelling, which is possibly a sarcoma in the calf muscle. And you have examined this lump very thoroughly, or the swelling very thoroughly. You have also examined whether the sarcoma has compressed the distal artery or not, whether there has been a fingertip gangrene or not. But you have not examined the proximal part of the limb. And this gentleman can have a metastatic lymph node in the inguinal region. So it is extremely important that you look at the L, which is usually the proximal part of the limb, to see whether there is any lymph nodal metastasis or not. Is it okay, Prajesh?
Yes, sir. Thank you, sir.
Any other questions? I mean, you can ask me any questions. See, when we are in a Zoom class, I am not able to see anybody. Okay, so an input from your side would actually help me. Okay. So Maya Kauti, do you have a question? Okay. Now we move to the next part. The left one remains the same. I mean, as we have already described. Now we move to the palpation. Okay. Now, when you are asked to, number one, to palpate, the first and the foremost thing is temperature and tenderness. So that becomes a mandatory must in all individuals. So I would not be repeating it in any case, be it an abdomen or a breast or neck or wherever it is, the temperature is not elevated or elevated and the swelling is tender or not. Then you come to the site. Now, as I said, a very important facet of site is the anatomical location. Now, you need to reconfirm the anatomical location. Okay. Now, Prajesh or Nayakoti, anybody, can you describe? Now, this is the patella, and this is where the knee joint is. And this is the sarcoma, which is maybe a big swelling, which is situated in the upper thigh. And this is the anterior superior iliac spine. This is the pubic tubercle. Now this is the patella. Now, can anybody describe me where exactly the swelling is anatomically located? Or can it be Nivedita? Yes, Nivedita. Can you describe the swelling? I mean, there is no negative marking on this. Okay. So is there anybody who would like to volunteer to tell me exactly where the swelling is anatomically located? Yeah. Okay. So if we don't have a volunteer, in that case, I would volunteer to tell you exactly where it is situated. I would rather describe that this upper edge of the swelling is, it's a swelling which is situated in the mid-thigh region on the anterior aspect. The upper extent of the swelling is situated, say, 5 centimeter from the anterior superior spine. The lower extent of the swelling is approximately 8 centimeter from the superior aspect of the patella. Laterally, it is approximately 5 centimeter from the lateral medial line. Sorry, laterally, not medially. It is situated approximately the medial end of the thigh. Laterally, it is approximately 4 centimeter from the lateral edge of the thigh. And if it is situated a bit more, you can also tell the lateral edge is situated approximately 3 centimeter from the pubic tubercle. And therefore, somebody gets a fair idea where exactly the swelling is situated. Clear? Now, the next thing is the size. Now, this is a very interesting thing. And very often, I have found candidates making mistake while they are being asked to assess the size of a lesion. Now, suppose you have a swelling which is situated, say, maybe in the thigh again, once again. Okay. So this is a swelling which is situated in the thigh. And somebody is asked to tell the size of the lesion. So of course, you are going to tell the size in both axes, that is the horizontal and the transverse and the vertical axis of the lesion. That's very sure. But when you are asked to measure it, very common mistake is to put the tape like this. So if you are putting the tape like this, which conforms to the size of the lesion or the disposition of the swelling, you are actually, if this is the size, which is X, you are putting it X plus 3. You are actually overestimating the size by 3 centimeter because your tape is conforming to the curvature of the limb. So that is wrong technique. So if you want to measure it, the technique that you should follow is, number one, you have to drop a tangential diameter and put in the tape to tell, sir, this is the size of the swelling. Or you can put in a vernier caliper here and measure the swelling to tell, sir, this is the size of the swelling. So it should not be a tape which goes like this. It has to be a projected size of the lesion or a vernier caliper which pushes inside and exactly measure the size of the lesion. Any confusion on this? Okay, so that actually tells you the size. The shape is quite frequent. Now, when you are describing the shape of a swelling, only thing that you try to remember is on inspection, your description is mostly two-dimensional. That means you can tell it's a circular swelling. But when you are palpating it, it can no longer be a circular swelling. You're going to describe, sir, this is an oval swelling or it's a pyriform shaped swelling. So you are actually adding a three-dimensional description when you are palpating a swelling. Whereas on inspection, it is purely a two-dimensional description. Clear? Now coming to the next point is the surface. Now the surface actually, when you are describing a swelling, can be smooth. If you find it to be smooth, it can be irregular. So depending on what you find, you are going to describe it's a smooth swelling or some irregular swelling or whatever you find. But that's pretty simple. Now coming to consistency. Now try to understand that a consistency has got certain things. Number one, swelling, when you are describing a swelling like this, can have various consistencies. Number one, it can be a consistency which is cystic. Number two, a consistency which can be soft. Number three, a consistency which can be firm. Number four, a consistency which can be hard. And in certain circumstances, when there is a big swelling with central degeneration, it can have areas of cystic and areas where it is firm, and that becomes a variegated one. So during the exam, do not tell it's a soft to firm swelling, it's hard to cystic swelling. Either it is cystic, or it is soft, or it is firm, or it is hard, or it is variegated. When you have a mixed nature, call it variegated. Do not tell soft to firm. And when you mention this term variegated, there are certain examiners who are very critical about examination, and they might ask you, demonstrate why you call it variegated. And you need to tell, sir, this is the area which I find it to be hard. This is the area where I found it to be soft. And this is the area where I could demonstrate fluctuation. And therefore, I call it a variegated swelling. But it has to be cystic, soft, firm, hard, or variegated. Clear? Now, just to remind you once again, firm or hard is a subjective way. I mean, it requires years and for us decades to understand and palpate and touch the iPad to tell that this iPad is actually hard. Whereas to touch your muscle to tell it's firm, or to touch a swelling to tell it is soft, these are all subjective things. The only way that you can tell that an objective way it is cystic is by demonstrating something called fluctuation. The fluctuation test is the only test by which you can tell that this swelling is likely to be a cystic swelling. Now, what I'm going to do is to show you how exactly I can demonstrate a fluctuation. Now, can anybody see what exactly I am trying to show you? Now, for a second, this is a swelling that I can see. Can you see this swelling?
Yes, sir.
Okay. Now, when you are asked to demonstrate fluctuation of this swelling, a very important first is number one, to fix the swelling. So I have fixed the swelling like this. Now look at this. I have fixed the swelling like this. The swelling is fixed in between my fingers. And then you look at this. I am pressing this and this goes up, or I am pressing this and these fingers are going up, and I'm pressing this and these fingers are going up. So a very important component is to fix it and then palpate it. So you can fix it. Suppose you are dealing with a hydrocele, you can fix the skin like this, and then you can actually press it like this to see the compressibility. Okay, Oshit, you want it to be explained once again?
Yes, sir.
Now look at this swelling. This is a hypothetically a swelling which I'm trying to replicate in a Zoom class. Now, if you are asked to demonstrate the fluctuation, do not jump and tell, sir, this swelling is fluctuant. A very important part first is to fix it. And you can fix it like this. You can fix it like this. And once you have fixed it, then you are going to move the swelling like this. On one side, you place it like this. The fingers, the fingers divulge. And you press it like this, the fingers divulge. And the uterus fluctuation is positive. This is number one. Number two, you need to change the axis now. In both axes, you demonstrate fluctuation. It's not only in one axis, but in both axes, you need to demonstrate the fluctuation. This is number one. Did everybody, Oshit, did you understand it?
Yes, sir.
Okay. Now, quite often, you are going to get a very small swelling. Now, for example, if I can show you a swelling which is situated, say, in front of my nose. I hope everybody can see my nose. Now, this is a very small swelling that you see. You cannot fix it like this or fix it like this and demonstrate it like this. So, a common technique is hold the swelling like this and press it like this. As you press, the fingers move apart. And for a small swelling, this is the best technique to demonstrate the fluctuation. So what you are doing when you are pressing it is you are putting the fluids on both sides, and therefore the swelling becomes fluctuant. If it is still smaller, say it is as small as the tip of this pen, and where you cannot actually place your fingers on both sides and do this. In this case, you put your fingers like this. If the central portion appears to be soft, then it's likely to be a fluctuant swelling, and the periphery appears to be firm. But if it's the reverse, then it's a non-fluctuant swelling. So basically, the fluctuation can be divided into three subtypes. And the subtypes are, if you are dealing with a large swelling, okay, then you are going to demonstrate fluctuation on this axis and then fluctuation in other axis. If it is a swelling which is small, then you put your two fingers on both sides and press in front to displace the fluid on both sides. If it's still smaller, then you just press the finger in the top. So large, medium, and this is a very small swelling. And therefore, the demonstration of fluctuation is different in three different types of swelling. As because it has gone off, so I'm going to put the 4S once again for you to recollect. So it is site, size, shape, surface, then C for consistency, in which a very important component is the fluctuation test. Then you have M, which is the margin. Then you have R, which is the reducibility. Then you have C, which is the compressibility. Then you have P, which is the pulsatility. Then you have R, which is the relationship. Then you have D, which is the distal part. And then you have L, which is the proximal lymph nodes. So we have completed the site, size, shape, surface, consistency. Now remember, when you are looking at the C of the consistency, apart from fluctuation, another very important thing, if it appears to be a cystic swelling. I mean, as I said, a swelling can be cystic, it can be firm, it can be hard, it can be soft, it can be variegated. Now, if it appears to be a cystic swelling, you may be asked to tell what is the likely reason why you call it cystic, and your answer is a fluctuation positive. Then the next question that is asked, what is the character of fluid that you see inside? And therefore, a test called transillumination comes. For which, what you are going to do is you are going to place the torch somewhere here. And while you place the torch somewhere here, you are going to place an illuminoscope, which is a rolled X-ray plate somewhere here. And if the light passes through this, the whole thing will turn, and as you look from above, from this region, you would be able to see that the whole thing turns illuminate. And I hope many of you have seen this test being done in the case of hydrocele. So in consistency, when you are telling it's a fluctuant and a cystic swelling, add the transillumination test to that. Clear? Transillumination test is being done. Okay, now coming to the margin. Now, as I said, now a margin can, when you are looking at a swelling, say in the abdomen, suppose. Now I give you a swelling which is situated like that. Okay. And this is the umbilicus, this is the midline. And so you are going to describe, sir, I can see a swelling, and this is situated in this and this place. Now about the margin. You are going to tell the medial margin extends up to the midline. It is well defined because you are able to palpate the whole thing here. So it extends up to the midline and it is well defined. Now I can see the lower edge of the margin of the swelling, which is also well defined. It extends up to just below the level of the umbilicus, and it is well defined. I would not be able to comment about the lateral margin as it goes into the flanks. It merges with the flanks. So I won't be able to comment whether it is well defined or it is ill-defined. Look at the superior margin. I could not reach the superior margin as the swelling disappears under the lower edge of the costal arch. And therefore, that is a perfect description of a margin. You have described the medial, the lateral, the inferior, and the superior margin. And as I said, the margins can have different characters, not in terms of only whether they're well-defined or ill-defined, but some of them might go underneath the costal arch, some of them might merge with the muscle laterally, and therefore the description is going to vary. And making a statement which is generic, that it is well-defined, is wrong. Clear? Anybody has a question on this, on the margin description? Okay. Now, if there is none, I move to the next part, which is the reducibility. Now, before we move to reducibility, I will take both these at a time. I mean, you have two terms. One is called a reducible swelling. The other, which is called a compressible swelling. Now, a reducible swelling is one. Now, look at this. This is a hernia, which is classically a reducible swelling. Now, a reducible swelling is one which disappears on applying pressure, or on lying down. It can disappear spontaneously. Clear? So it disappears on lying down or on application of pressure, but reappears only when somebody strains. So the straining can be coughing, or it can be blowing, it can be doing a Valsalva maneuver, whatever you do. But the strain has to come for the swelling to reappear suddenly. So a reducible swelling is one which is defined as a swelling which disappears on application of pressure on lying down and reappears only when the individual coughs or strains or blows or puts in a Valsalva maneuver. So that is a reducible swelling. Whereas a compressible swelling is one which you put in a pressure, it disappears, you release the pressure, and it spontaneously starts filling up like this. Clear? So can anybody guess what can be the likely content of a compressible swelling? Any guess? Anybody? I mean, there is
So
no negative.
fat,
Yeah,
fat.
fat. Who was this? This is Devyani, isn't it? Now, Devyani,
Yes, sir.
yeah, if you press it, now for a second, you try to press on the fat of your forearm. It is not going to disappear if you press. It is going to be there. So no, fat is not going to. So there's a suggestion from Ishita Laha. The answer she suggests is blood. Now Ishita, Prajesh, now let me take Ishita. Ishita, can you tell me why exactly you think it can be blood?
Sir, hematomas are compressible swellings.
Hematomas, that means a collection of blood.
Are compressible swellings.
Partly yes, but not completely. Now your answer, Prajesh, you told edema, you press it, it disappears. It takes a lot of time for the whole thing to come back. But when we talk of compression, you put in your thumb, you put in your thumb like this, you put in a pressure, it goes down like this, you release the thumb and the whole thing. Amit, you have the correct answer. I can't give Amit. Amit tells it's hemangioma, perfect, because it is going to refill. Now, why would it's not a question of hemangioma. It is a vascular malformation. Now, why would a vascular malformation behave like this? Now, look at this. This is a swelling, the skin, and you have a swelling like this. And the swelling is connected with an underlying blood vessel. So when you press it, the blood enters into the main vessel and it disappears. Once you release this, the whole blood once again slowly comes and fills it up. And therefore the whole thing reappears. So Amit, you are bang on, your answer is correct. Did I make sense? Did everybody understand? Rishita, you understand? A hematoma on the other side, that was the answer given by Rishita possibly, is an encysted collection of blood. It is likely to be more fluctuant. It is unlikely to be compressible. So a compressible is, or Ishita suggested it's, Rishita suggested that it was hematoma. You are very close, but it's an encysted collection. So it is going to be a fluctuant one. But a vascular malformation is likely to be a compressible one. You press it, it disappears. You release, it reappears. Whereas a reducible swelling does not reappear once you release it. It only reappears when somebody coughs. Is it clear to everybody what is a compressible swelling and the reducible swelling? You can put in a thumbs up too, so that I'm sure that you understood it. Is it okay? That's fine. Now I go to the next one. That is pulsatility. I mean, again, these three RCP are very close. Reducibility, compressibility, and pulsatility. Now, why are they close? The reason is very clear. Now, try to understand. I told you that all swellings which are collected by an encysted, within an encysted place, are cystic swelling and they are fluctuant. I told you a swelling which is connected with a vessel inside is compressible. Now, it depends on whether it is a compressible swelling with a connection with an artery. If it is connected with the artery, it is likely to be pulsatile
ఒకడే
swelling.
కేస్ ప్రెజెంటేషన్ చెప్తున్నారంట 2 days ఆస్ కేస్ చెప్తున్నారంట.
Okay, Ravi. Now look at this. Now we were suggesting a swelling which is like this, which has got a vein going like this, and there are multiple communications, and they form the last vascular venous malformation where the blood is connected with the main vein, and this is a venous malformation. Now instead of this, if there is a swelling which is connected with the artery, then it is going to be compressible as well as it is going to be pulsatile, because it is going to carry the pulsation of the artery in its wall. So a compressible swelling which is pulsatile, and the way you do it is by trying to put your two fingers on this side. So this is technique one. Once again, I will go back. I only hope that I do not lose whatever I have written. Now look at this. Now this is a swelling. Can everybody see? Now technique one is trying to put two fingers on top. Now I have put in two fingers and the fingers move up like this. This is one. So it means that there is an artery beneath and it is pressing the swelling up. So the fingers are moving up like this. The second is this swelling itself is originating from the artery. So the fingers move like this. So this is an expansile pulsation. The second way is this is a swelling, a small one. I can hold it like this. If my fingers are moving up like this, then it's a transmitted pulsation. If it is moving like this, it is an expansile transmission. If it's a bigger swelling in the abdomen, then I can put my fingers like this. If they move up like this, then it's a transmitted pulsation. If it moves out like this is an expansile pulsation. So depending once again, what type of swelling, how big the swelling is, how big the swelling is, we can tell whether it is a transmitted pulsation like this. Number one, depending on whether it is sitting on it, when we call it a transmitted pulsation, or it is directly collected with it when we call it an expansile pulsation. Clear? So I have to write it down once again for you. Number one is 4S, which you have done. Now C is consistency, and we have fluctuation with that. Then then you can have transillumination with that if it is a cystic swelling. I will come to that, Ashit. M is margin, R is reducibility, C is compressibility, P is pulsatility, and when we talk of pulsatility, it can be transmitted or it can be expansile. Then we have R, which is relationship. Then we have D, which is the distal limb. And then we have L, which is the lymph node. Now, what was your question, Ashit?
Sir, during position change, is the transmitted pulse goes off?
No, not really. Not really. If the swelling doesn't hide underneath a bigger structure, the transmitted pulsation is going to be there. Clear?
Okay.
Okay. So that brings us to the next, the third core area that we were dealing with is the relationship of the swelling with the surrounding structure. Now, Aishwarya, you have a question? Okay, you can ask the question. Okay, so yeah. Now, when we talk about the relationship of the swelling, try to understand that we are talking about a swelling which is situated here. We are talking about the relationship with the skin. We are talking about the relationship with the muscle. We are talking about the relationship with the bone. We are talking the relationship with the surrounding fat. Clear? So of the skin, it is skin pinching. You try to pinch the skin up, you are able to do though, and you know the skin is free. Now come to the underlying structure. Now, when we look at the underlying structure, we are going to try to move the swelling in this direction, in this direction. If we are unable to move it, move in both directions. You are unable to do so. It is fixed to bone. That is the underlying structure. Clear? Now you are able to move it. That means this swelling moves to this and the swelling moves to that. You are able to move it. Then you do not know. It may be fixed. It's for sure it's not fixed to the bone. That is sure. So the bone is out. It may be fixed to the muscle. It may not be fixed to the muscle. So the next step will be to understand whether it is fixed to the muscle. For that, you need to make the muscle taut. So, for all of you who are into this class, they need to remember that you must know all the muscle tests and how each muscle is being made taut. I mean, that begins with the sternocleidomastoid, the masseter, the pterygoids, the deltoid, the bicep, the brachioradialis, the pectoralis major, the flat muscles of the abdomen, the erector spinae, to the hamstring, to name any muscle of the body. You must know how to make them taut. And then you make the muscle taut and then try to remove it. If you can move it, unable to move, then it is fixed to muscle. If you are able to move it, then it is free from muscle. So remember the algorithm. Number one, skin. If I am able to pinch the skin, it is free from the skin. Number two, try to move the swelling in both axes. If I am able to do so, then it is free from the bone. If I am unable to do so, it is fixed to the bone. Now I make the underlying muscle taut, whatever the muscle is situated at that area. And now I once again try to move it. If I am able to do so, it is free from the underlying muscle. If I am unable to do so, it is fixed to the muscle. Is it clear to everyone? Any questions? Okay. If somebody could put in a thumbs up, I'm sure everybody understood. That's a sample. That's it. Okay. So that clears about the relationship. Now I told about the distal limb. Now, not quite infrequently, we are going to guess, as I said, about that unfortunate candidate who was actually brilliant and jumped at looking at the swelling in the groin and started telling it's a femoral hernia and didn't care to look at the distal limb. Now, why it is important? Now, examination of the distal limb is important because of two reasons. One, if you are palpating the swelling as a lymph node, like you get a swelling which is in the inguinal region, and you get a swelling here which is a swelling, you think it's a lipoma, you open the lower extremities, you find a carcinoma here, and that is a metastatic node. Number two, there can be an infection in the nail, and that is an infective node. So therefore, the distal limb examination is very important if you find a lymph node. Number two, whether the swelling is compressing the artery, the vein, the lymphatics, or as I said, very importantly, the nerve. So you must look for the pulsation of arteries distally. You must look for edema for both them, and you must do the neurological examination to exclude a possible compression. So that would mean why you would go for the distal limb examination. Any clarifications at this point?
Sir, repeat again, sir. 3%.
Okay. As I said, the reason why in an examination of a swelling, the distal limb becomes very important is number one, because if you are palpating a lymph node and you have not examined the distal limb, you might miss a carcinoma or a focus of infection. So this may be the secondary one, and the primary pathology may be lower down. The second reason, if a swelling is there and the swelling is compressing on the underlying artery, vein, or the nerve, you can get the following features. So therefore, you need to examine the pulse, arteria dorsalis pedis, in case it is compressing the femoral artery. So the pulsation of the artery needs to be examined. If it is compressing the femoral vein, you need to examine whether the limb is swollen and there is edema or not. If the lymphatics is compressed, the same thing, if there is edema or not. Whereas a lymphatic will give rise to a non-pitting edema, and the vein is going to give rise to a pitting edema. And finally, if the nerve is compressed, then you get a neurological deficit. That means either there can be a radiating pain along the course of the nerve, or there may be signs of neurodeficit lower down. Clear? Okay. Now we
Thank you,
come
sir.
to the final part, that is the lymph node. Now, as I said, we were discussing about the distal limb. Exactly the reverse is also important. That means you have been given a case where somebody has presented to you with a mole here, which is diagnosed as a melanoma, or a cancer here, which is a squamous cell cancer. And you have described the swelling very nicely, but you have not looked at the popliteal lymph nodes. You have not looked at the inguinal lymph nodes, and the examiner comes and shows you that you have missed a lymph node. So if you are dealing with a swelling here, you must examine the whole limb down. If you get a swelling here, not only this part, the part above also needs to be examined. So it completes both the distal and the proximal examination. In the distal examination, it is mostly the artery, vein, lymphatics, and neurodeficit. Whereas in proximal, it is mostly the lymph node. Clear? Okay. So that brings us to the end of clinical examination of a lump or swelling. I think we should be stopping here today. We will take a different class of soft tissue swellings. I mean, it starts from the sebaceous cyst down up to a sarcoma, and then we will discuss every detail of how you are going to diagnose each of them and how you're going to investigate and come to a treatment. So you can ask me any question related with the examination of a lump or a swelling. Any questions? Okay. So if there is none, Rudra, would you like to have a concluding statement?
Yes, sir. Thank you a lot. It's a fantastic class. It's a very conceptual class. Remember, swelling is a very, very slippery topic, especially to examine in the undergraduate as well as the postgraduate, even more so in postgraduate, because you are not expected to slip up on a description of swelling. So if there's no more question.
There is one question. There is one question from Prajesh.
Okay, go ahead. Can you see the question? Hello?
Sir, regarding the positioning of the torch and how, whether the লাইটটা পাস করলে কি হবে সেটা বুঝলাম না।
Okay, I think he is out of. Okay, there he is there.
Then I have to put in a torch at a place where I am sure the light is going to pass unobstructed. It should not be placed very close, because if you place it very close, the light is going to percolate here, and that would give you a false positive one. If you are doing it in the testis, in the scrotum, and the testis is lying between, and you have placed it here, so the light is going to get obstructed, so that is also going to make it false negative. So it has to be placed in a position where it is not close, and it is placed in a position so that nothing comes in between, so that there is free flow of light to your illuminoscope, and it is not so close that it passes to the fat underneath to give you a false positive impression. Is it clear, Prajesh?
Yes, sir.
Okay. So thank you again, Diptendra, for your fantastic lecture. And if there's no more questions, I will conclude this session. So thank you for attending it. Our next session will be again on Friday for the undergraduate, and the postgraduate will be on Monday. Thank
I
you so
think
much, Diptendra.
Rudra, if I could
Yeah.
request you that if you can have a class on swelling, I mean the differential base, because we need to talk on vascular malformations to lipomas, what they are asked during the exam,
Okay.
because mandatory they are going to get one class. So if we
Definitely.
discuss, if it permits, then we can have a discussion on this sometime.
So will this be on one class, or do you want to split it into two?
I think we will require two class, because because swelling is something which everybody needs to cover, every single one.
And you can't slip up in the exam because of that. That's a sure thing.
No, absolutely not.
Okay, sir. We will think about. We will let them know by the weekend when can we plan this out. Okay.
Okay, thank you very much.
Thank you so much, Diptendra. Thank you all of you. So have a good night. Right.
Thank you.
Good night, everyone. Good night, everyone.
Thank you, sir.